So we're just waiting for our next speaker. But first of all, I'm going to introduce Dr. Lucy Thomas. So it's a real pleasure to introduce Lucy, who's a consultant dermatologist at Chelsea and Westminster. And as I only found out today, she's also dual trained as a pharmacist, which I think may be the only consultant dermatologist in the UK. I don't know, but it's very impressive. So she has a lot of different areas of interest. She's published many articles involved in clinical trials, but currently she is actually doing a project on AI, and she'll be talking to us about the AI-driven future of dermatology. So thank you very much, Lucy.
Okay, thanks so much, Emma. It's fabulous to be here today. It's a real privilege to stand alongside this amazing group of colleagues and this fantastic set of lectures that have been organised by L'Oréal today. So I just thought look, this title's a little bit interesting, isn't it? It's a bit intriguing. Innovating for all, a collaboration and an AI-driven future of dermatology. But what I really want to do is to walk you through the sorts of challenges that are facing dermatology today and why we urgently need to innovate and how we can go about actually doing that in practice. I'm then going to share some details about a unique partnership which we think is going to be a real game changer before honing in on one of the most exciting frontiers, which is artificial intelligence. So these are my disclosures, and in particular, I do work as an independent consultant for Skin Analytics, which is an AI company, and we are going to be talking about some of their software later. And I've also received charitable grants, and we'll touch on that a bit later in the presentation. So I thought we'd kick things off with a bit of good old-fashioned audience participation. So don't groan, but if you can all just stand up out of your seats. Okay, great. So I want you to stay standing if you've noticed that urgent cancer referrals have been increasing in your clinic or at your hospital over the last couple of years. Okay, good. We're on to the right lines. So everyone's still standing. I want you to put your right hand high up into the air if you think that patients with inflammatory skin disease are waiting too long to receive treatment. Okay. Excellent. Keep your hand in the air. I now want you to use your left hand, touch it down onto your knee, okay, if you think that you've struggled to recruit to any dermatology posts in your trust in the last couple of years. Okay, starting to get a little bit lopsided. And now if you really want to test out your balance, try and stand on one leg. If you think that you're struggling with managing clinical care, you're providing teaching, you're supervising students, you're doing research, you're doing audit, all at the same time. And the reality is that this is what it feels like, doesn't it? We're juggling all of these competing demands on our time, whilst always striving to give the best care for our patients. But if we take a hand and we put it on the seat next to us, it steadies us, and that's what using tools like artificial intelligence does. It doesn't take away all of the challenges, but it helps to give us the space to be able to breathe, to move forward, and make some sensible decisions about how we want to practice. So please take your seats. Thank you for humouring me with that. So these are the challenges that we're facing day in, day out. And at times, I think it feels a bit like this. We've got this bathtub overflowing, and we're bailing it out with a teaspoon, when really what we need to be doing is turning off the tap or pulling out the plug. And obviously, workforce is a huge problem. It's a big pressure point, and we know that 1 in 4 dermatologist posts in England are unfilled. And also, training numbers have been restricted for a number of years now. And that leaves us with a long-term shortfall in dermatology specialists. In primary care, skin conditions account for about 20% of GP consultations, and yet most GPs lack any specialist dermatology training and often only receive a few days whilst at medical school. We're also seeing an increasing number of physician assistants and paramedics in the front line who often have even less dermatology training And I'm not sure whether you've noticed it, but we're certainly seeing an increasing in number of advice and guidance requests and lots of inappropriate referrals into secondary care. Dermatology sees the most cancer referrals of any specialty, and that figure is rising by 10 to 15% every single year. But at the same time, conversion rates for melanoma and squamous cell carcinoma are actually decreasing. So in 2019, it was about 8%. By 2022, it was below 7%. So that means we're working harder, but we're not diagnosing more cancer. I'm sure we're all far too familiar with the FDS targets, which dictate that patients should have cancer ruled in or out within 28 days. And we've seen significant improvements towards this target across England in recent years. And that's taken heavy investment in teledermatology and changes in how we deliver care, and probably a little bit of how we report things. But 30% of patients with cancer still don't start treatment within 62 days. And the last time the NHS met that target was actually back in 2015, which is a long time ago now. And this reflects a lack of foresight and capacity downstream, particularly in terms of surgical capacity. Now, at the same time, I think what frustrates many of us is that waiting times for patients with inflammatory skin disease and those on routine pathways is getting longer. The target is that 92% of patients should start treatment within 18 weeks of referral. And as of early this year, nearly 9,000 patients actually breached more than 12 months. And we know that it's not just AKs, mild eczema, acne on these pathways. It's actually patients with severe, debilitating, chronic inflammatory disease that is severely impacting their day-to-day life. Often they struggle to work, to study, form relationships, and it has a massive psychological burden on them. But also, it includes a third of our urgent cancers. So how do we even begin to tackle this huge problem that dermatology is facing? Well, we really need to think differently. We need to step outside the traditional box, and that's where innovation comes in. So innovation means introducing new ideas, methods, products, or services that make a meaningful, positive impact. And I don't know about you, but it's not something that I was taught at medical school, and it's actually not something I've even come across at many of the dermatology conferences. But it's absolutely essential to delivering sustainable, high-quality care. And I really like this diagram here from Stanford University, which maps the whole process from identifying need at one end right through to prototyping, implementation, and refining your service. But innovation for me started with frustration. And as a junior doctor, I was appalled with the poor use of resources and the level of waste. And so I decided to act. And with one small change, which was making pathology costs visible at the point of request, we saved over £1 million each year in pathology requests at our hospital. This solution worked because it was simple, it was light touch, and it was intuitive. And so I want you to remember that. These things don't have to be complex to make a really big impact. So when innovating, I think that there are 5 essential questions to ask yourself before you start. So first of all, clearly, what exactly is the problem that you're trying to solve? So here, it's clear that demand is outstripping capacity. But we need to dive deeper, and we really need to understand exactly where the bottlenecks are in your local area. Number 2, what are the potential solutions? And this is where you really need to get creative and to collaborate. So getting as many different people from different backgrounds to contribute their ideas is where actually you start to get some really interesting solutions. Number 3, what resources are available? And it's not just about the money. It's about skills, it's about infrastructure, but most importantly, it's about time. Number 4, what's realistically going to be achievable? We might say, let's lobby government to increase the pay for dermatologists in the NHS, or increase the training posts. But the issue is that that's not really within our control, and it's probably going to take a huge amount of time to actually get there. So what can we do now? And 5 is finally, what will give you the biggest impact? What's going to give you the biggest bang for your buck? So let's be honest. Innovation in the NHS is hard. It looks a little bit like this. It's pretty bleak. It's not by any means because there's a lack of ideas. I think within this room, I'm sure loads of people have got ideas about what they'd like to do. But it's definitely about the environment. We've got fragmented systems. We've got siloed data. We've got bureaucratic processes that really kill momentum. I'm sure many of you have been involved in pilots that never get any further. And it's about having a very risk-averse culture that favours the safe and the known, even if what we're doing in the status quo is actually causing harm. And so on top of that, there's also chronic lack of investment, foresight, and dedicated clinician time to actually driving change. And so that's why I'm incredibly excited about the groundbreaking partnership that we launched earlier this year between Chelsea and Westminster Hospital and La Roche-Posay. And this is the team at our first joint meeting up at L'Oréal headquarters. And this is really about combining strengths. So the NHS brings clinical expertise, a trusted voice, and patient access, whilst L'Oréal brings technical know-how, resources, and huge global reach. And by working together, we believe that we can really accelerate change that truly benefits patients and clinicians alike. And so what La Roche-Posay are actually doing is supporting us to deliver faster diagnosis, better access, and improve outcomes. Crucially, what they've done is fund dedicated clinician and project management time that gives us the breathing space and the support to actually innovate properly. And we've structured the partnership around these 3 pillars, which are knowledge generation, education, and raising awareness. So I'm going to go into these in a little bit more detail. So firstly, in terms of knowledge generation, we're monitoring and sharing real-world data on how AI is transforming dermatology care here and now. We're also developing a better understanding of who's starting to fall through the cracks. And from that, we're building more inclusive data sets, which are focusing initially on patients with darker skin tones, but also with patients with rare skin cancers, as well as difficult anatomical sites. And we're also mapping clinician, patient, and societal attitudes towards AI, because by understanding the barriers to adoption, it's really important if we then want to actually widen access. And through all of this, we want to position the UK as a global leader in AI for dermatology. Secondly, education. So for clinicians, we want to share what works and what doesn't. And we want to do this by building toolkits, by providing webinars and implementation guides. No one needs to reinvent the wheel when it comes to these sorts of projects. For patients, we're creating accessible resources that are inclusive, multilingual, and multimedia, so that everyone can actually understand, trust, and feel a part of this new way of delivering care. And finally, raising awareness. And this is, I think, is where the partnership becomes incredibly powerful. So by combining the NHS's trusted voice with L'Oréal's global reach, we can educate the public on skin monitoring, early detection, and safe sun practices. But we can also start to challenge misinformation with evidence-based co-branded campaigns. And we can start to build a conversation around equitable, inclusive skin health that's preventative, not just reactive, but is also fit for the future. So now let's focus on one of the most exciting areas of innovation, which is artificial intelligence. Now, back in 2017, Chelsea and Westminster set up the UK's first teledermatology service for urgent cancer referrals. And I'm going to walk you through this pathway because it's relevant to seeing how it all fits together with AI. So the patient sees their GP with a lesion that they're worried about, and hopefully the GP can reassure them it's fine and discharge them. But of course, if not, they're going to refer them on the urgent cancer pathway. But instead of going to a clinic, they get an appointment in a photography hub with one of our clinical photographers. At that appointment, they complete a questionnaire, they complete consent, and they get photos captured with a digital SLR camera as well as a dermoscopic lens attachment. And all of this information is then uploaded into the medical records and is reviewed by a consultant dermatologist within 48 hours. And at that point, that dermatologist can decide to either discharge the patient, providing timely feedback and education, or they can request an urgent or routine clinic appointment, or they can send the patient directly for surgery. And as with all good innovations, we've steadily streamlined this pathway over the years. So we've improved referral quality, we've automated communications with patients, and we've introduced dedicated administrative support, which has all added to the capacity gains that we've been able to reach. We've also set up a follow-up teledermatology clinic for low-risk lesions, which Louise Fairfield here is a pioneer for, and that's been hugely successful. So we've been able to free up capacity, reduce unnecessary biopsies, but also prevent patients from being lost to follow-up, which is a huge concern when we sort of get these patients off the cancer pathway and they disappear into the ether and we're never quite sure what happens to them. So whenever you innovate, it's absolutely essential that you collect baseline data. And often we're so excited to get started with this new project that we miss this bit out. And it's absolutely disastrous if you do, because you can't track improvements. And that when it comes to then wanting to justify further investment, you've got no data to use. So fortunately, we did think about this before we did it. And our teledermatology data showed a slightly lower rate of discharge compared with face-to-face appointments, which probably you'd expect. But there was a dramatic fall in minor operation requests, and overall, we were actually able to double capacity. So it gave us significant capacity gains. And this model of work and the team won the BMJ Dermatology Team of the Year in 2020, and it was later recognised as an exemplar by NHS England for outpatient transformation. But frustratingly, despite these efforts, it just wasn't enough. Referrals have continued to increase. The pandemic hit, routine waits spiralled, and we were forced to rely on unsustainable, costly private insourcing, as many units around the UK have had to do. And so in 2022, we partnered with Skin Analytics as part of an AI in Health and Care award to deploy artificial intelligence across our urgent cancer pathway. And to do this, we use an AI called DERM, which stands for Deep Ensemble for the Recognition of Malignancy. And it's a CE Class 3 medical device that's powered by AI to recognize the most common malignant, pre-malignant, and benign skin lesions. And it uses a simple smartphone with a dermoscopic lens attachment, and it provides a diagnosis and management plan within seconds. The analysis part actually happens in 3 stages. So firstly, the AI will confirm that the image it's looking at is in fact a dermoscopic image. Next, it checks that the image quality is adequate. And finally, it goes on to classify that lesion using a hierarchical approach, always giving precedent to the more serious diagnosis to prioritize patient safety. So for example, if a lesion mostly looks like a seborrheic keratosis, but maybe has 1 or 2 features that are ticking the box for melanoma and it crosses that threshold, then it would automatically be upgraded to the high-risk pathway as a melanoma for ongoing evaluation. And so how does that fit in with the pathway that I described to you before? Well, you can see in this blue box on the right-hand side, when the patient comes for that photography visit, the photographers take an additional image with this smartphone and dermoscopic lens attachment. And if the AI deems the lesion to be high risk, so pre-malignant or malignant, then it just carries on and is reviewed by the trust teledermatologist remotely. If the AI deems it to be benign, then that lesion was going on and being reviewed by a dermatologist employed by Skin Analytics, and they could either agree, yeah, let's discharge this case, or they could upgrade it into that high-risk pathway for a remote teledermatologist review within the trust. And the process was a huge success. And so in December of last year, we took the bold step of switching to an autonomous pathway. So now, if DERM deems the lesion to be benign, then that patient is immediately discharged with robust self-monitoring and sun protection advice, but no clinician review. And to fully understand the magnitude of this step, Chelsea and Westminster and West Suffolk were actually the first hospitals in the world to use an autonomous pathway in any cancer care. So why on earth did we feel confident to take such a radical step? Well, firstly, it was around performance. So over the preceding year, we could see that in our population, Derm detected 100% of invasive melanomas and squamous cell carcinomas and over 97% of basal cell carcinomas. So pretty impressive. From a scale perspective, we'd seen over 10,000 patients during the time we'd deployed it. We could see discharge rates of 25%. We saw cancer conversion rates increase by 67%, and also we were able to process a quarter more patients in the same time frame, giving us that much-needed capacity that we wanted. We were also fortunate to have several independent evaluations, some from Edge Health and also from Unity Insights, which validated the data that had been provided by Skin Analytics from their various deployments and also supported its use within the NHS. Internally, this wasn't something that happened overnight. We'd been building towards this over a period of 12 to 18 months. And because there was this lack of national guidance, we had to basically create the guidance ourselves. So we had to go around and get key stakeholders involved and really build on their specific expertise to ensure that we had a really robust process that was safe and appropriate for our patients. And that meant engaging with clinical governance, our clinical safety officer, the communications team, procurement, legal, patients themselves, clinicians, of course, and pulling that all together to get to a point where we were happy to proceed and that our executive board was happy to sign this off. And this schematic highlights the various opportunities we identified for risk mitigation, and I can go into this in detail later, but for example, with the consent, we had to make sure that patients were given the opportunity of opting out of automated consent, of automated decision-making. We had to train our photographers, our clinicians, our administrative staff, and we also sought that independent legal review. We also co-developed a unique post-marketing surveillance strategy, and you'd think that this already exists, but it doesn't. So we had to kind of start from scratch and think, what's the responsible way of deploying this in a way that we can safely collect data, ensure that harm is not resulting? So we have loads of audits. So we're regularly auditing image quality. We're looking for repeat attenders, so people coming back into the system with the same lesion. We're auditing whether inclusion and exclusion criteria are being applied appropriately. We're also looking at whether Derm is labeling enough cases as melanoma and SCC as we would expect for our population. And every single case that goes through the pathway has a ground truth diagnosis. So if that's for a cancer, it will be histological, and if it's benign or pre-malignant, it will be histology if it's available, and if not, consultant dermatologist diagnosis. And of course, if there aren't any missed cancers, then we have a full root cause analysis which takes place. And at Chelsea and Westminster, we've gone one stage further. So we've also implemented a follow-up text messaging service to actively try and search for those missed cancers. And that's across the whole of the cancer pathway. So not just for patients discharged by AI, but also for patients who are seen face-to-face in clinic. And that's been funded by NHS England, and we're busy collecting that data at the moment. And we've also chosen to route patients with Fitzpatrick 5 and 6 skin types for further trust dermatology review, and I'm going to touch on this a little bit later. And with the autonomous pathway, this is the performance. So you can see it really nicely, and this again is why it's so important to have that data for the various different models. So you can see on the left, you've got your face-to-face, then you've got your plain teledermatology, then you've got the AI teledermatology with the second read review, and finally on the right-hand side in orange is our autonomous pathway. And you can see that the AI typically discharges about a third of cases without relying on any clinician input. And that's bumped up to around 56% with remote teledermatology reviews. Follow-ups reassuringly remained low, but minor ops compared with that face-to-face appointment were reduced by over 20%. And overall capacity increased significantly. And what that's meant for us is that we've been able to pull back from that costly, unsustainable private insourcing, which quite frankly was a bit of a disaster. But also, this summer was the first time that we haven't had managers on our backs whilst we've been on annual leave, asking us to put on extra clinics at evenings, weekends, etc. So this summer has been very different to what we've experienced over the last 10 years. And we were delighted that in May of this year, our decision was further validated by NICE, who granted conditional approval for derm to be used in urgent cancer pathways across England. So we're coming to the end now, but as someone who never wants to miss an opportunity, I thought I'd strike while the iron was hot and tackle some of the myths that are currently floating around about artificial intelligence. So number one, AI isn't as good as a dermatologist. What do you think? Well, it's a bit tricky because as dermatologists, we're not really very good at monitoring what we do. We don't go around checking to see if the patients we've discharged actually end up developing cancers. And NHS systems aren't really very good at tracking clinician performance either. So let's look at the evidence. And you can see here there have been a number of systematic reviews and meta-analyses. And these show varying degrees of sensitivity for dermatologists when diagnosing particularly melanoma, that's where the bulk of the data is, but there are studies generally for skin cancer diagnosis and the odd few looking specifically at squamous cell carcinoma. And the sensitivities you'll see range from the low 80s to around a maximum of about 95%. Now, in comparison, derm sensitivity for invasive melanoma is 98%, and for SCC, it's 97%. So that's higher than those meta-analyses. And if we look on the right-hand side, specifically at the EDGE report, the negative predictive value was 98.9 for face-to-face dermatologist assessments and 99.8 for derm AI. Myth number two. AI isn't generalizable for my population. Well, it's a really important question to ask, and it's something you really need to think about when you're examining new tools that are coming to market, because quite often we see AI tools that have been used in academic studies, and then you go and put them into real-world practice, and they don't perform anywhere near as well. Similarly, if you put them in one patient population in a particular country and then move to another country, that may not translate. But when it comes to the derm AI, it's been deployed now at 28 NHS sites across urban and rural locations. And it's been used in populations with incidence rates that range quite significantly across different ICBs that you can track here. A prospective study that we did in the derm deployments of 25,000 lesions across 12 of those sites showed superior sensitivity to teledermatologists for all urgent cancers across these diverse populations. And in a separate study, we looked at some of the 15 post-referral sites, so that's where it's being used in secondary care, and we saw that 13 out of 15 had these sensitivity levels above that 95%. Of the two that were just below, the actual confidence levels actually crossed that 95% level, but also they were generally very small sample sizes, and so the data was a little bit misconstrued. So number three, AI doesn't work for darker skin tones. Again, this is a really hot topic, and there's a lot of misinformation out there. It's really important to understand, firstly, that only 0.5% of skin cancers in the UK actually occur in Black and Asian patients. And these patients are actually disproportionately more likely to be detected on routine pathways rather than urgent skin cancer pathways. The percentage of patients with Fitzpatrick 5 and 6 skin that are seen on the AI pathways that we've just looked at across all of those deployments actually is around the same as the percentage of Black and Asian patients referred in on urgent cancer pathways. Now, I get that they're slightly different metrics. There's certainly issues in terms of classifying skin tone, and that talking about ethnicity is not always a comparator, but it's the best data that we have. In terms of performance, though, Of the several thousand patients with darker skin tones who've been assessed by the AI, it has in fact detected all 44 of the cancers, and that includes BCCs, melanomas, and squamous cell carcinomas in those Fitzpatrick type 5 and 6 skin. But I think most importantly, excluding these patients from AI pathways actually risks worsening inequalities. So it's crucial that we include people in order that we gather more data so that we can prove that it's validated and we can ensure that it's safe and widen the access to a more diverse population. And what we've been able to do is include darker skin tones to be assessed by the AI, but then they're automatically routed for a teledermatologist review. So we feel that that safety net works really well and it doesn't widen that healthcare disparity. And the final myth, these results are just unique to Chelsea. It's different in Chelsea. We wouldn't get the same results elsewhere. Well, we wondered about the same thing, but we deployed exactly the same pathway at our sister hospital, West Middlesex, and that has a very different population cohort. And yet, actually, when you look at the numbers, the results were pretty similar. So I think on this front, I would say it's implementation that is the key factor and not postcode. So perhaps the real ethical question isn't, is it safe to embrace AI? It's, is it ethical not to? When current practices are stretched to breaking point and patients are waiting months and years to access effective treatments, can we actually justify not using these proven technologies that can increase capacity and improve accuracy? So this is where we started. Things looked pretty bleak. We were overwhelmed, under-resourced, and firefighting on a daily basis. But I hope that I've given you a glimmer of light. I think with creativity, collaboration, and the right partnerships, we can really start to transform dermatology care. Let's move from an NHS that's on the brink to one that's flourishing, that's innovative, and that's leading the world in dermatology care. So my call to action is simple. I want you to think differently, to be bold, be confident that you can make a difference and make change happen, and just do it. Okay. If anybody wants to find out any more, this little, I know you're like death by QR code today, but if you want to just scan this, it will give you the opportunity to just pop your email address in. So if you want to find out anything more about artificial intelligence and the pathways we've been using, then feel free to pop your details in there. Thank you.
Thank you, Lucy. That was incredibly impressive, and I think really does pave the way for a whole new sort of era in diagnostics. And I think something that you mentioned is about, let's make the UK the forefront of this, because other people will be. It's not going anywhere. AI is not going anywhere, so let's try and be at the forefront, and your work's incredibly impressive.
Thank you.
So we've got a few questions, and we've also got some roaming mics. So if anyone has a question, please put your hand up and we'll bring you a mic. Meanwhile, on the QR code, someone's asked, would it not be more appropriate to roll AI lesion recognition direct into primary care and train GPs to take dermoscopic images?
Brilliant question. And half of it, yes, half of it, probably no. So the reason that we started with this project in secondary care was it's very difficult to collect data in primary care because you'd have to recruit so many different GP practices to get the volume of data that you need. And so we felt it was the right place to start this in secondary care, also whilst you've got that specialist oversight. But there is absolutely no doubt that the position for this is very much in primary care and ultimately in the hands of patients. And we won't be that far off that. I think when it comes to primary care, and we've certainly seen this with teledermatology, we've looked at various different models, GPs are under huge amounts of pressure, so their time is very limited, and getting them to take photos, which I know we're asking them to do, can be difficult, and we can see varying levels of uptake. I think that there is certainly a role for it. I think if you've got engaged GPs that want to use it as a decision support tool, that can be really helpful. But I think that what we're working towards is probably these community diagnostic hubs where essentially GPs can just send these patients straight to the hub, not on a cancer pathway, but just with a lesion. They complete the questionnaires, they get the photos captured, and if the AI deems it to be high risk or pre-malignant, at that point, they then go onto that cancer pathway and they're automatically referred into secondary care. And if not, we know that we can then be discharging those patients, but with really robust advice. Because I think at the moment, that's something that we're not particularly good at, and there's a wide variety of practice across the country within primary care and also in secondary care.
Fantastic. Perfect. Up here.
Thank you. I'm Bernard from South London. I've got two questions. One is regarding pediatric dermatology and whether or not this is being implemented, / does that actually help with the anxious parent? And then my second question is around the face-to-face work. Have you had to change your the template for face-to-face work? Because essentially with AI and with telederm, you've skimmed off the easier patients, the solitary lesions. You then end up with multiple moles, frail patients, elderly patients, and those with mental capacity issues in your face-to-face. Has that changed your workload? Has that actually increased burnout for those who do face-to-face work? Thank you. Good
questions. So I think when it comes to pediatrics, yeah, we don't have the data yet. I think that's going to be a while off. I don't know how much lesional work there is in pediatrics. Yes, there's a certain amount, but probably looking at AI tools for managing eczema in pediatrics would probably give you much better efficiencies. I think when it comes to templates, so about 10 to 15% of patients on an urgent cancer pathway are not appropriate for teledermatology, and so they will still need to be seen face-to-face, and they're usually patients with ulcerated lesions on lower legs often, multiple lesions or genital lesions. And so there is still a requirement for that face-to-face clinic. But that's also important because actually we don't want to stop seeing patients altogether in clinic. And it's also important from a training perspective. Certainly, it's really important to, whenever you make any change, definitely pilot about how long it's taking you because, yeah, there's one thing about getting faster and quicker and more efficient, but actually, if what you're then suddenly seeing is way more complicated, then actually you've done yourself a disservice. And so we've been really careful about that in terms of our teledermatology clinics. And despite all of the more complex cases coming through, actually, we've still been able to see those efficiencies. I think that this is something that we're not very good at, though, when it's come to more the general clinics. So we're seeing all those ERS triage cases coming through. We are really getting through the easy stuff and sending that back to GPs. So now general clinics must be the biggest source of burnout there is. I don't know how people get through them. And I think actually now you need to be looking probably at more like, half-an-hour appointments in general clinics to actually manage these more complex cases. So yeah, it's a balance and definitely something that you need to be aware of.
What's a question there?
Hi. So the data is very impressive for the sensitivity, but do you have any data about the specificity and the number needed to biopsy, so number of pigmented lesions needed to biopsy one melanoma?
Yeah, so the specificity was on that slide. It's in the mid 70%. Obviously, whenever you're working with artificial intelligence, it's always going to be a balance of trade-off of sensitivity versus specificity. So sensitivity being your ability to diagnose cancer, specificity your ability to diagnose benign. And it's all about that level of risk. And if you want to discharge more patients and get that specificity higher, that will usually be at the cost of missing more melanomas. And so at the moment, we feel that we're at the sweet spot. I mean, I think a 30% reduction in clinical workload is quite significant, but we're still keeping that sensitivity level above that 95%, which is what we see as dermatologist performance generally in the literature.
And what's the equivalent for dermatologist specificity? Do you have that data?
We don't have, it's very poorly reported. In terms of number needed to biopsy, I don't have the exact figures, but we did this study with Louise, who's just sat behind you, and we actually showed that the number needed to biopsy was lower with artificial intelligence than in face-to-face clinics for melanoma. And I think it was down to, was it about 6? Yeah, it's about 6 cases to diagnose 1 melanoma, which is pretty good. I think if you're at about 9 or 10, that's considered good. Okay.
Fantastic.
Sorry, just have one more question just over here. Thank you very much for the talk. It was really helpful. My name's Kira Haddadine. I'm a consultant at Epsom and St. Helier. So we've had a lot of meetings with Skin Analytics and across the Southwest London network, where our colleagues Kingston and St. George's are doing different things at the moment, so Telederm and Skin Analytics. So we're kind of deciding which is the best way to go, because we have a funding for a pilot. However, we are hearing things that, Telederm is not enough on its own, Skin Analytics also not enough on its own. Some trusts are still doing evening lists and weekend lists, but they may be possibly in earlier stages, because I know Chelsea has been going on for a while. I just wanted to ask, are you still using Telederm as well for routine general dermatology, or have you stopped that completely, or how are you managing with your general patients as well?
Yeah, so I think that this goes back to thinking about implementation is key when it comes to these sort of new ways of working. And it's actually down to the detail to make sure you get the most efficient process in place if you want to get the best out of it. We've never done teledermatology per se for general dermatology, because actually now most of the referrals are coming in with photos, and so they're already being triaged. So every referral coming through is being looked at by a consultant and either being discharged back to the GP with advice or being booked into the specific clinic that is supposed to be appropriate. So that's our form of teledermatology, I guess. But we've not done it formally with patients coming into the trust for photos and capturing specific questionnaires. But it is something that we're looking to do as part of these community diagnostic hubs, and seeing whether we can sort of have a single point of entry for dermatology. Is that helpful?
Thank you.
Yeah.
Fantastic. Thank you so much, Lucy. We will have some other questions later. There's some coming through, but thank you very much.